times of COVID-19. But one of the wonderful aspects of life is that we get perhaps to see each other far more often through virtual, if not real and personal. Truly, virtually, we see each other far more frequently, and the world's certainly got much closer to each other while we fight this war against this pandemic. But we're certainly closer, both with our thoughts as well with interchange and exchange of knowledge and education. I think today is a very exciting session. I know that many of you who are listening do believe that it's a pandemic of webcasts as well, but rarely do you get such exciting topics with up-to-date knowledge being covered by a spectrum of national and international stars gathered together all in one screen. And that's a rarity. And I think, therefore, for me, certainly, the reason I've accepted to moderate this session is because I'm keen to learn as well. And it gives me the opportunity. Therefore, I have to attend this session. I'm bound to attend this session. And I'm bound to learn from the great exchange which is going to happen between the speakers as well as the panelists that we have. And who do we have here? We have, our friend, Dr. Adnan Kastrati from the German Heart Center. Who doesn't know him? I mean, he's set the standards for research and science for many years. Much of what we practice today is based on the trials that he's performed, the ISAR series of trials, which have truly been path-changing and path-breaking in many ways. We have from the German Heart Center, Dr. Jens Wiebe. And again, I hope I pronounced the name correctly. And if I haven't, I'm sure by the end of today, I will learn how to have said it correctly. But apologies if I haven't done so. But again, it's wonderful to have you here and welcome. And then, of course, the stars, the international stars of this country who you all know about, have heard so much before, but they're truly thought leaders. And that's why they're here on the panelists. Dr. Upendra Kaul, my colleague, co-moderator, who is the chairman and dean of academics at the Batra Hospital and Research Cardiac Center. Dr. Hirimath, who is the director of cardiac cath lab at the Ruby Hall Hospital, Pune. Dr. Singer Tuvelu, who's an interventional cardiologist and structural heart disease specialist from Apollo Hospital, Chennai. We have Dr. P.K. Hazra, who's the head of Department of Cardiology at AMRI in Kolkata. We have Dr. Anil Dhal as the head of cardiology at the Janakpuri Super Specialty Hospital. And of course, Dr. Samuel Matthew, I'd say one of our senior most members and certainly one of the greatest pioneers India has seen for a long time, the director of interventional cardiology at Apollo Hospital as well as in Mumbai, and Dr. Ashwin Mehta, our guru, Ashwin Bhai, our guru, from the Jaslok Hospital in Mumbai. Praveen, my colleague, fond friend, as the chairman of interventional cardiology from Vedanta. And then we have Thomas Alexander from the Kovai Medical Center. With these words, I would like to hand it over to my colleague, Dr. Upendra Kaul, to take on this session and the first part of the session. Over to you, Upendra.
Thank you very much, Ashok, and thank you very much, all my friends. All of us know each other very well. And as you said, that we see each other more often than we used to before March this year. And I hope that, we start seeing each other physically also now. And let me start, we're going to have a session by Dr. Wiebe from German Heart Center, giving us a complete, a brief summary of what we should be knowing about all the intervention trials which were presented, which were discussed during the European Society of Cardiology meeting held recently. So over to you.
Oh, thank you very much for this very kind introduction. And yes, you pronounced my name absolutely correct. And I'm very happy to present these highlights from the ESC, and I hope you will find my selection of interest. So there are three topics I would like to talk about. First, antiplatelet therapy. Then I would like to talk about news from stable coronary artery disease. And last but not least, about myocardial infarction. There were three interesting trials presented at the ESC meeting on antiplatelet therapy. And I would like to start with the HOST-REDUCE-POLYTECH-ACS trial, which has a very complicated name, but it was very interesting. So this study was performed to investigate the efficacy and safety of a prasugrel-based de-escalation therapy in patients with acute coronary syndrome who underwent stent implantation. And the hypothesis was that this prasugrel de-escalation strategy will be non-inferior to a conventional strategy. So this is the study design. Patients with ACS underwent PCI with second-generation DAS. All patients received aspirin plus prasugrel 10 milligrams for 1 month. And according to the randomization, then patients were treated with prasugrel 5 milligrams for 11 months or stayed on the 10 milligrams prasugrel until the 12 months were complete. Here you can see the baseline clinical characteristics. Approximately 1,200 patients were included in each group. Mean age was about 58, 59 years, and the most of the patients presented an unstable angina. Here we have the Kaplan-Meier curves for the primary endpoint, which was NACE, or net adverse clinical events, which is a composite endpoint of all-cause death, myocardial infarction, stent thrombosis, repeat vascularization, stroke, and bleedings according to BARC class 2 or 2 to 5 classification. So the rate for the composite endpoint in the conventional prasugrel group was 10% after 1 year and 7.2% in the de-escalation group. This difference was statistically significant, and the p-value for non-inferiority was clearly reached. The authors also made a landmark analysis after 30 days because all patients received the same treatment within these 30 days. And again, the rate of this combined endpoint was significantly higher in the group of conventional prasugrel treatment. Here we have the key secondary outcomes. And you can see regarding cardiac death, MI, stent thrombosis, or ischemic stroke, there were no differences seen between both groups. But when you have a closer look at the safety outcome and the bleedings according to the BARC classification, class 2 or higher, you can see that the bleeding rate was significantly higher in the prasugrel 10 milligrams group. So the authors concluded that this de-escalation strategy was effective and resulted in a lower risk of this primary endpoint than the conventional dose strategy. And these events, or this event rate, was mainly driven by bleeding events. The next interesting study on antiplatelet therapy is a subgroup analysis from the large SWEETHEART registry. This is a nationwide myocardial infarction registry, and the investigators had a closer look in patients who were 80 years or older at discharge, and they compared if they received a dual antiplatelet therapy with aspirin plus Ticagrelor or aspirin plus Clopidogrel. The outcomes were assessed according to the ICD-10 codes. This is a very large registry with a total of 125,000 patients, and for this cohort and this analysis, 14,000 patients were eligible, and 40% of them were treated with the dual antiplatelet therapy with Ticagrelor and 60% with Clopidogrel. Again, the baseline characteristics were very similar between both groups, and the mean age was 85 approximately in both groups, which shows that this is a true elderly patient population. Here we have the clinical endpoints, and first the combined endpoint of MI, stroke, and death, and there was no difference seen between the treatment with Ticagrelor or Clopidogrel. And when also including readmissions for bleeding, again, there was no difference seen between both treatment strategy. But when you have a closer look at the individual components, you can see that the risk for myocardial infarction and stroke was lower in patients treated with ticagrelor, but on the other hand, the risk of death and bleeding was higher in patients treated with ticagrelor. So thus, the authors concluded that in this observational analysis, ticagrelor should be used with caution among these elderly patients older than 80 years, and of course, you always have to balance out the individual ischemic and bleeding risks. Of course, I have to present the results from the ISAR-Plaster trial, and Professor Castrati is the principal investigator, and this trial was also, of course, conducted at the Deutsches Herzzentrum in Munich. Just to give you a background, GP6 is a collagen-binding receptor which is expressed by thrombocytes, and it plays a key role in platelet activation and aggregation in case of vessel wall damage, for example, during PCI and balloon inflation. And Revacept is kind of a soluble GP6 which seals the vessel wall damage, and thus the adhesion of thrombocytes will be inhibited, but at the same time the systemic thrombocyte function is not impaired. This study was to test the efficacy and safety of Revacept in patients with chronic coronary syndrome undergoing PCI and who also received standard DABT. The study was investigator-initiated, multicentric, randomized, and double-blinded, and the primary endpoint was death or myocardial injury, which was defined as a significant increase in high-sensitive troponin T, and this endpoint was evaluated after 48 hours. A total of 334 patients were randomized and allocated into 3 groups and received either periprocedural Revacept 160 milligrams, 80 milligrams, or placebo. Here are the baseline characteristics, and there were no statistically significant differences found between the groups. The mean age was around 67 years, and more than half of the patients had a previous history of coronary artery disease and treatment. Here we have the results for the primary endpoint, and you can see the rate for death or myocardial injury after 48 hours was 24.3%, and there were no differences found between the groups, and it has to be noted that there was no death occurring within these 48 hours. Here we have the peak values of high-sensitive troponin, and there were also no differences found between all of these 3 treatment arms. When having a closer look at the platelet functions measured at 48 hours, you can see that the most effective platelet inhibition or platelet function inhibition was reached with Revacept 160 milligrams. After 30 days, the MACE rate overall was 2.5% and very low, and there were no differences found between the groups. And there were also no differences found regarding bleeding events between these 3 groups. Thus, in conclusion, a higher dose of Revacept provided a more pronounced platelet inhibition without increasing the bleeding risk, but Revacept did not have a significant effect on myocardial injury in these CCS patients who had a low ischemic risk. So this was the first part on antiplatelet therapy, and I would like to proceed with stable coronary artery disease. And I found one very interesting subgroup analysis from the ischemia trial, which investigated patients with impaired left ventricular function and heart failure. And they defined heart failure or left ventricular dysfunction as prior heart failure or left ventricular ejection fraction lower than 45%. Here are the baseline characteristics of these patients, and they were overall very similar, but of course, and as expected, the ejection fraction was 60% in patients without heart failure and 44% in patients with heart failure. On this slide, you can see the outcomes. The overall outcomes are respective of the treatment of patients with or without heart failure, and you can see for all of these endpoints, or nearly all of these endpoints, that the outcome, the clinical outcomes, was impaired in patients with heart failure. Here we have the outcomes according to the treatment strategy in patients with or without heart failure. And you can see, for example, for the primary endpoint, that patients with heart failure undergoing an interventional strategy, they showed better results compared to a conservative treatment strategy. In this case, the primary endpoint was a combined endpoint of cardiovascular death, MI, cardiac arrest, and hospitalization for heart failure or unstable angina. Thus, the authors concluded that an invasive approach may be beneficial in this subgroup of high-risk patients with evidence of ischemia and history for heart failure or left ventricular dysfunction. There are two further studies on myocardial infarction, which I would like to present. One is about bioresorbable scaffolds in STEMI patients. And this is a pooled data analysis from the AIDA and compared absorb. And the authors compared 350 patients with STEMI treated with absorb against 328 patients treated with XINES. The baseline characteristics, again, were very comparable. However, it has to be noted that the rate of diabetes was higher in the absorbed group. And here are the Kaplan-Meier event curves for 24 months. And the rate after 24 months was 8.4% of target lesion failure in the group treated with absorb and 6.2% in the group treated with XINES. This was not statistically relevant. However, when having a look at the definite device thrombosis, you can see that the rate in the absorbed group was 4.7%, which was nearly threefold higher compared to the XINES group. This is an overview over the clinical results, and you can see that there were no differences regarding most of the endpoints between both groups. And as I already told you, the scaffold thrombosis rate was higher in the absorbed group. And this was also appreciated in the conclusions of the authors. Last but not least, I have very interesting subgroup analysis from the complete study. Just to give you a quick reminder, this was a study of patients with STEMI and multi-vessel disease, and patients were randomized to be treated by complete revascularization or by culprit lesion only revascularization. The median follow-up was 3 years. And the authors found that the rate of cardiovascular death or myocardial infarction was significantly lower after complete revascularization. And the same for this further combined endpoint, including ischemia-driven revascularization. The authors made also some very interesting subgroup analysis. And in this slide, you can see they compared the time point of the completion of the revascularization against the treatment with only culprit lesion revascularization. And you can see that irrespective of the time point of complete revascularization was favorable over culprit lesion only treatment. They also made a QCA analysis of the lesion severity, and they assessed the outcomes according to the diameter stenosis of a non-culprit lesion against culprit-only lesion, complete revascularization. And you can see when the diameter stenosis of the non-culprit lesions was more than 60%, patients had a clear benefit. And when the diameter stenosis of the non-culprit lesion was less than 60%, there was no difference found compared to a non-culprit lesion only revascularization strategy. There was also a subgroup analysis from 100 patients who underwent OCT imaging at the site of the non-culprit lesion. And interestingly, they found that 50% of these lesions were thought to be unstable. So, in conclusion of this study, the QCA, or the severity of the stenosis, is very relevant and an important factor when you have to choose of complete versus non-complete revascularization strategy. And the OCT sub-study demonstrated a very high incidence of unstable lesions. So this was a very large amount of information, and so these are just on one slide my personal messages from these studies I presented to you. So in ACS patients, a de-escalation strategy showed a decrease of clinical events, mainly driven by a reduced rate of bleedings. Ticagrelor is associated with an increased bleeding risk in patients over 80 years. VIVO provided a more pronounced platelet inhibition without increasing the bleeding risk. An invasive approach is beneficial over a conservative approach in patients with coronary artery disease and impaired LV function. After 2 years of follow-up, the rate of device thrombosis was significantly higher in patients treated with bioresorbable stents in the setting of STEMI, and 50% of the non-culprit lesions in STEMI patients are unstable. Thank you very much for your attention.
Well, thank you very much. I think all these trials have been very interesting trials, and most of us sitting here during the ESC were focused on the hotline trials only, which were very important. But I think we're getting a lot important information from all the studies which you chose to share with us, and I think they're of a lot of practical importance. So let me take my panel, and you're already there. First of all, let us talk about the trial on Prasugrel, because after your group's study of the ISAR showing that in acute coronary syndromes, Prasugrel is better than Ticagrelor, and we are very impressed. In fact, I was very impressed by that because of many reasons, because we have a large diabetic patient population, and in the original TIMI study, also TIMI-Triton, diabetics, the Prasugrel had a much better result than Clopidogrel. And somehow, because of the bleeding things, it started getting shelved, and then Ticagrelor came in such a way, at least in our country, it's being used in all kinds of PCI, stable, unstable, acute MI, everything. So now this bleeding thing, 10 milligrams for a month and then de-escalating to 5 milligrams, showing equivalent efficacy and lot less bleeding. I think it impresses me. So let me ask my panel. Let me start with Shirish, who does a lot of acute MI PTCA. Have you gone back to Prasugrel? No? No, you're muted. You're muted. You are muted. Yes.
No, we have not gone back on Prasugrel. Too early to do that.
No, not because of this trial, because this is a trial after trial coming for Prasugrel's benefits, and Prasugrel is much cheaper than Ticagrelor.
The issue is when there is a call from the ER, we had to say yes, no for many when you analyze Prasugrel versus Ticagrelor. But there are few no's for Trica and many no's for Prasugrel. That was one of the reasons I felt always and see. Switch from Tica to regular, no reason to do that in the early phase. So that is how I think Ticagrelor was used more often in many of these.
Ashwin, what do you say?
Okay.
Ashwin, your opinion regarding Prasugrel, and now that we know that we can reduce the bleeding further by de-escalating the dose to Japanese dose of 5 milligrams.
Upendra, basically, I don't treat very often the acute myocardial infarction with intervention in view of the junior team usually attends. And I think same like Sirish that we have the same problem, that we have not switched over to Prasugrel and continue using Ticagrelor.
Praveen?
Basically, as you are hearing now, that most of us are now hooked on to ticagrelor in a very big way. But certainly there are a group of patients where we do use prasugrel. One, of course, as Dr. Hiremat also mentioned, and you mentioned, cost is one of the issues. If cost is an issue and you are doing acute MI, 100% we go to prasugrel, and especially in young patients. So that is one very important indication which I have today for our patients where we just use prasugrel. The second very important indication is in those patients who are not tolerating ticagrelor, because still there are about, I think, maybe 15-20% patients who come up with dyspnea at some point in time, and where we have given multiple stents where then we switch them over to prasugrel if there is no contraindication to prasugrel. So prasugrel still remains with us and we still do use it, and this is very interesting observation from this de-escalation therapy. I think that makes a quite interesting, maybe we'll start using them as a de-escalation in slightly higher bleeding risk patients.
Well, before I go to my Indian colleagues, let me go to Adnan, who has, brought in this prasugrel back into business from the ISAR study and now this one. What do you do in German Heart Center and your other center, Adnan? Mute. You're muted. You're muted.
So, just to tell you an anecdote, if someone of our colleagues makes the mistake to give ticagrelor, we get phone calls from family physicians and also from some patients why we are not respecting the results of our study. This is the situation here.
Okay. So that means you're not using?
We are not using it anymore, ticagrelor, only for those patients who have contraindications or something. But it's gone.
Okay, good.
Because
good.
you have to understand that ISAR-REACT-5 study reflects also our strategy. Yes. Because it's most of them, about more than 80% were treated with PCI, and it was a very short interval between randomization and PCI. So we are not belonging to the centers who are waiting for patients with ACS to send them to the cath lab.
So,
I ask a question?
Yeah, go ahead. I think the discussion should happen with also Sengatuvelu and Anil and Hajra coming in.
That's right. So what is the, now prasugrel 5 milligrams once a day after 1 month, doesn't it appeal you? 2 tablets of ticagrelor with 20% or 15% getting dyspnea, and not a very attractive proposition to me with more and more data coming. So Sengatu and Hazra and Matthew.
Yeah, if I come in, so if you allow me to speak, Dr. Hazra here. Look, sir, there are a lot of trials which coming from multi-center and multi-nation. Then there are trials, single nation, single center, single nation, multi-center. And the whole world criticize the type of trial because it's coming from South Korea and multi-center. So single nation, single center. Now, ISAR-REACT came from Germany and most probably Italy and Denmark. Though it is a multi-center, again, it is not generalized to all populations, whether it is transatlantic or Indians. Now, after Twilight ACS and Ticagrelor trial, we have come down to 3 months in ACS and STEMI. Now, perhaps with ticagrelor and very potent P2Y2 inhibitors like prasugrel, we don't need aspirin at all after 3 months. That is quite certain now. Now, whether you can come down to 1 month with prasugrel, yes, the data are there from ISAR-REACT-5 and these HOST-REDUCE. So perhaps it is quite appealing, sir.
I was just thinking that in this trial, there was a third arm with a single drug, maybe after 6 months, because all were DAPT. One was 5 milligram prasugrel, and maybe the third arm with one drug, we would have known the efficacy and the safety of a single drug as well compared to the 5 milligram versus 10 milligram.
Yeah. So I think we have been discussing prasugrel at length. Let's hear Anil's view on the.
So my view is a little.
No. Let us go to other subject now. Otherwise time will be.
But I just want to make a small point here.
Sure.
So my view is a little counterintuitive because I have always believed that prasugrel is a very potent agent, and the dose which Eli Lilly had come up with 60 milligrams of loading and 10 milligrams of daily dose was excessive and contributed to all the black box warnings and all the high bleeding risk issues which are there with it. So the Japanese dose has always appealed to me, and I think it's coming back, and we should not hesitate in going back to 5 milligrams, even in medically managed patients. Even the earlier trials have not been against 5 milligrams of prasugrel.
And now that you have shown that in the elderly people, ticagrelor is also having more bleeding. It's not that age is limitless for ticagrelor. That also is not true. So let us come to Dr. Matthews and come to stable ischemic heart disease, ischemia patients. That is, patients who have got very little or mild symptoms and more than 10% ischemia, means a lot of ischemia, and have an ejection fraction less than 45%. What was his, way of treating these patients before, and now that we have some evidence also that possibly invasive is better? Yeah, you're muted. Unmute. Matthews, please unmute. Yeah.
Patients with compromised cellular function, we always prefer to intervene whenever it is possible. And the results, what we have seen is very similar to what we experienced also. I don't think it has changed philosophy or our management strategy. We always believed in that, we continue to do that. That is getting confirmed by this study.
Ashok?
I won't comment here because I think there are others who should be just joining in here. But I think I wanted to raise a very important issue along the prasugrel. While we see, this is a study from Korea, and I think I wanted you to comment on the fact, and that's I wanted Dr. Wheel to comment on the fact about whether it is generalizable. After all, these are small people. The body weight is a very important feature of the efficacy of prasugrel. So the 5 milligram, is it generalizable to the West? Is it actually, especially Germans? I mean, Germans are huge people, while Koreans are half their size. That's a very relevant, critique, and I think I want you to comment on that.
So I absolutely agree. As you all know, Asian people usually have a larger risk for bleedings, and Korean people, and lower risk for thrombosis, stent thrombosis, and that's absolutely something that needs to be confirmed in further population. On the other hand, we have also seen some studies like the Tropical ACS trial, in which was also a de-escalation strategy in Europe very successful.
Correct.
So there are no data available regarding prasugrel, and I think this is an important issue that you also prove in other countries.
Yeah. I think we should move to the next talk, if that's okay with you, Pendra.
Yeah, absolutely. Yeah. Because the other studies, IDA and others, that BVS is gone complete. We know that complete revascularization is the answer. We additionally know that culprit vessels have more, thick fars also, and that is an additional benefit of treating them.
Can I just make a short comment? This the trial with the absorb, with ACS has shown stent thrombosis at 2 years, which is a bit of surprise because we have seen very late scaffold thrombosis in most of the other trials. So here we have shown at 2 years, which is a little surprising.
Good.
Can I ask this one last question about this complete trial? So basically, I was not very clear whether the complete revascularization was done at the same hospitalization in the study, or at different time, like it was done within 30 days or within 7 days or at the same time. So there are 3 time points: same time, within hospitalization, or 30 days.
And the other issue is whether FFR was used or just a QCA.
Right, I think, Hiramat, you are right. I think they had done 60%. And we know that the angiographic 60% lesion might not be ischemia-producing lesion, physiologically.
Yes.
So it wasn't physiological, it was angiography. And
it was angiographic, eyeballing. Yeah.
So when was it done? Like at what time?
Well, I think Dr. V might be able to tell better, but I think they were done mostly in the same hospitalization. Yeah.
So
they were not discharged. Yeah.
So they did not differentiate between a complete revascularization between index PCI or during index hospital stay. So this was just one big group, and they called it completization of revascularization during the initial hospitalization. And they also did not give exact time point when they did the complete revascularization after the initial hospital stay.
So basically, it was, I think, tackling all the culprit regions which the operator felt should have been done without, flow and pressure and everything else, just by morphology of the lesion.
So I think we're going to move now to the next talk. Thank you very much. That was a good discussion with everyone's involvement, and I would now like to proceed to the VIVO ISAR dual drug DES. Is it the final frontier in DES technology? I think the data, or 10-year data, was presented on this, and I therefore hand it over to Dr. Adnan Kastrati, who's done some seminal work. Obviously, this is a part of the ISAR series of trials, and Dr. Adnan Kastrati, over to you for presenting this topic. So is your slide share working?
Yeah,
Dr. Kastrati?
Yeah, I am trying.
Okay, good.
Not very successful. Are you seeing that?
Well, we started seeing, yes.
You
just have to go to your
slideshow.
Good.
Ashok, thank you very much for your nice words, and it has been always a pleasure to be with my Indian friends and top cardiologists of India. So at this time also. It is a bombastic title, as you see. It is the final frontier in DES technology, but it's not necessarily to give an affirmative answer to this question. We'll see at the end of my presentation. So, drug-eluting stents has been a story of success and concerns at the same time. After a few years of big enthusiasm, there were some data that showed that there are patients having late stent thrombosis, as in the case here, Lancet 2004 from the group of steroids. And also, you know about the firestorm in the Congress of Cardiology 2006 in Barcelona. And here was not only stent thrombosis, but also mortality, which was increased with the Cypher stent. So after this mixture of enthusiasm at the beginning and also this fears for stent thrombosis, so I wrote this editorial and I put the question, is the future of drug-eluting stents as bright as their short past? But I was very optimistic at the time, and so that the answer to this question was, it will be. So there have been concerns with polymers as an explanation for the increased late stent thrombosis rate, and you see here the data from the study from Schwartz and Germani, and you see what they said here. Several animal models exhibit inflammation from stent coating and drug-reducing polymers. The perfect polymer remains unknown, and all polymers in use today induce some degree of inflammation. So polymers went from bad to good and to bad again, and you see here data from a study published in Circulation 2011, where the polymers have been protective against thrombosis. Let's see this data here shown in this graphic here. This is the comparison between bare metal stents without polymer and drug-eluting stents with polymer, and you see the thrombogenicity in this animals getting DES was lower. It is the same difference as it was created between thick stents and thin stents. After that, we know, and you have also seen the data from this Congress of Cardiology with longer-term follow-up of absorb in STEMI. This is a meta-analysis from Dr. Cassese in our center, who pulled all the studies with absorb, all the randomized studies with absorb against science, and there was an increase in the risk of stent thrombosis with absorb, which was higher in 12 months, but even higher in 2 years. The same was true also for target lesion failure, which was more negative for absorb. That's why from the beginning we were interested to look at alternatives of the polymers. And the first step we did in our research was to look at the surface of stent, which allowed more a higher load of substance of antiproliferative drugs. We knew also from other experimental studies that the rough surface improves endothelialization, and you see here the data from Palmas that the rough surface reduces neointima, as shown in this study published 2000. And what we did, we took two similar stent designs, and with one macrostructured surface and the other with polished. And you see the difference in the pictures here. This is a very polished surface, which was normal at the time, and this is the microstructured surface. Our intention was to look whether the microstructured surface infers a higher risk of stent thrombosis, a higher risk of restenosis in these patients before going to use this surface for drug-eluting stent technology. This was a small study, a 200 patient study. We showed that angiographic restenosis was even lower with microporous stent as compared to the polished stents. On the other side, there was no case of stent thrombosis in this small series of patients. The next step we tried was to get the optimal dose of sirolimus to use with these stents. And this is the first publication, 2005. We took 4 doses of sirolimus, so placebo, and then 0.5%, 1%, and 2% in a study comprising 602 patients. And you see that both angiographic restenosis and clinical restenosis as target lesion revascularization were going down with an increased dose of sirolimus. After choosing the dose, we went to use the microporous surface stent for coating with sirolimus. And you see here the results, the preclinical results with 2 kinds of coating. One, polymer-free sirolimus-eluting stents, and one with biodegradable polymer sirolimus. You see here the results of the vessel wall reaction to this 2 kinds of coating. With bare metal stent, you see a lot of endothelialization, very few inflammation, and fibrin. The same was true also for the stents without polymer. And with the use of biodegradable polymer, you keep the same endothelialization rate as for bare metal stents, but you get a little bit more fibrin while the inflammation was kept low, as in the case of bare metal stents. Just to see the release kinetics here, what you see is a very fast release kinetics without polymer and a slow down release kinetics with biodegradable polymer sirolimus eluting stent. What we did is next, we took 605 patients and included them in a randomized trial of 3 rapamycin eluting stents with different coating strategies. One, for clear, was Cypher at the time, the only sirolimus permanent polymer-based drug-eluting stents. And on the right side, you see the black bars showing the results for the polymer-free drug-eluting stent. And on the left side, you see the biodegradable polymer rapamycin eluting stent. So if you look at the angiographic restenosis, you see that the angiographic restenosis was higher with the polymer-free sirolimus eluting stent, and it was comparable between the biodegradable and the permanent polymer-based drug-eluting stents. The same pattern was seen also for clinical restenosis, that means target lesion revascularization in these patients. So what we understood from these initial studies was that to get a better anti-restenotic result, you need a slower release kinetic of sirolimus. The problem was at the time how to achieve it. So you could achieve it with biodegradable polymer, but you can achieve it also by the use of other substances such as propofol. Propofol was chosen at the time because propofol is very lipophilic and it slows down the release kinetics of sirolimus at the same rate as achieved by the biodegradable polymer. On the other side, there have been also positive data as an anti-restenotic drug with propofol. If you remember the publication in New England Journal of Medicine for patients undergoing PTCA. We looked at the preclinical data with propofol plus sirolimus eluting stents, and you see that the inflammation was very, very low, and the diarization was very good, and the fibrin deposition was lower than with the biodegradable polymer. After that, we went to the proof of concept trial, which was not a small trial. It was a trial of 1,007 patients. And we took here 3 kinds of stents and compared them. First, the Cypher, which was the most used stent at the time in our center. It was the new stent with dual drug-eluting stent, that means sirolimus plus propofol. And as a comparator, also, we took the newcomer at the time, the Endeavor stent, which was a sirolimus eluting stent. And you see the result. You see that with sirolimus eluting stent, it was the first generation, the Endeavor stent, not the Resolute stent. The restenosis rate, both angiographically and clinically, was higher, and you didn't see a difference between the propofol sirolimus eluting stent and the Cypher stent in this study. After that, we went to the biggest trial we have done with the drug-eluting stents in our center, the ISAR Test 5 trial, which included 3,002 patients with de novo lesions. And we compared the novel dual drug-eluting stent with sirolimus and propofol in 2,002 patients, and sirolimus eluting stent, which was the new generation, the Resolute sirolimus eluting stent in 1,000 patients. We looked at angiographic data at 6 to 8 months at 12-month clinical follow-up. The most important results from this follow-up were the very low stent thrombosis rate with both of the stents up to 12 months. It was about 1%, 1.2% for both. And you see also very, very similar results regarding angiographic restenosis, as shown here from the late lumen loss. This is the biggest, probably the biggest angiographic study for drug-eluting stents worldwide. Then we went up to see the outcomes after 2, 5, and at the end after 10 years for this randomized trial. The results were published now in summer in Journal of American College of Cardiology. And you see here the cumulative incidence of the primary endpoint, the MACE rate up to 10 years. It is very, very similar. The curves, you cannot distinguish the curves between each other there. And I have to say that most of the events, of the late events here, had to do with late mortality in these patients. You have to imagine there are patients about 70-year-old as they entered the study. And most of the deaths here, the late deaths, were non-cardiovascular deaths. So it's exactly this outcome that is affecting the results at 10 years, less the stent-related events. If you look, for example, at the stent thrombosis rate up to 10 years, you have seen the results after 1 year. It was here. And very, very few stent thrombosis happening after the first year. And even here, you don't see any difference between the two stents. Numerically, you can say that the dual drug-eluting stent was a little bit better, but no significant difference. So as I said, the most sensitive parameter for comparing the stents at 10 years is probably the stent thrombosis rate, and that's why I have put here all the trials. Well, the randomized trials with a 10-year follow-up regarding stent thrombosis. Here is the CTAX trial, which the results were published 2016, and they show the definite stent thrombosis from the CTAX. You know that the CTAX trial was a comparison between Cypher and Taxus, both first-generation drug-eluting stents. And you see a stent thrombosis rate, a definite stent thrombosis rate, about 6% without any difference between the two. Although at the beginning it was better for the Cypher. Look at the at this other trial here, the SORT-OUT 2 trial, which published the 10-year results in Journal of American College of Cardiology 2017. It was also a comparison between Cypher and Taxus, and here we have definite plus probable stent thrombosis, and it is very high, about 10% at 10 years for Taxus, and also about 8% for Cypher. Look at the results we had in the dual drug-eluting stent, in the VIVO ISAR stent, which was very low. But you may say it is not a fair comparison because all these are first-generation drug-eluting stents with a known higher rate of stent thrombosis. Let's look at another trial, ISAR test 4, which had the science as a comparator in the trial. And you see that the stent thrombosis rate in the VIVO ISAR stent group was numerically lower than in the science stent group of the ISAR test 4 trial. You know, now it has been the publication of the ONYX trial, ONYX 1 trial, and here are the results of the definite probable stent thrombosis with another type of polymer-free drug-eluting stents, the BioFreedom stent, and you see that it is above 2% even after 1 year in this trial. But we don't have longer-term data for this type of stent. So I could say that the eVIVO ISAR dual drug-eluting stent is a technology with a strength of about 25 years of research on optimization of stent design, as you have seen the trials about the strut thickness and also about the microporous surface. It's rich of preclinical features of drug-eluting stents we have investigated. It's also based on optimal dose finding, as I showed with the clinical study with 600 patients. It has been based on proof of concept trials with 600 to 1,000 patients, mostly with angiographic primary endpoints. And also with very large clinical trials, 2,000, 3,000 patients, which included also angiographic restenosis as a parameter, and very, very long-term outcomes up to 10 years. Now, what I can say with all this data coming from several studies done with the VIVO ISAR drug-eluting stent, Although an overall long-term superiority of this special polymer-free dual drug-eluting stents over best-of-the-class durable polymer DES cannot be claimed on the basis of evidence, it might offer the best candidate for a safe earlier discontinuation of DAP after PCR. Where to now for drug-eluting stents? And we wrote an editorial last year, Progress in Drug-eluting Stent Technology. Have we come to the end of the road was the question to answer there. And the answer was more effective and durable prevention of restenosis will remain a target of locally applied treatments even in the years to come. This will still require further improvement in DES technologies, including adequately tailored drug release kinetics, development of new antiproliferative drugs, and metal or bioresorbable stent or scaffold technologies. So thank you very much. And this is also my idea for the future. It will go very slowly because we have very good results now, and it will be very difficult to improve on top of these very good results. Thank you very much.
Thank you. Thank you very much, Adnan, for not just the study itself, but for progressing science very systematically for all. I mean, you were the one who showed that thinner strands were better than thicker struts. You were the one who demonstrated how polymers could actually, or getting polymer-free stents could actually be beneficial, at least at that particular time. So the concepts were correct. But let me just dwell on this, and I'm going to therefore will bring in my colleagues into this discussion. So it's fine. In the late 2000s, we were concerned about the polymer in the generation of first generation drug-eluting stents. And that was our emphasis, and that's why the biodegradable polymer stents came in and the polymer-free stents came in, your concept about the polymer-free as well as progressing to the dual drug delivery without a polymer. But in the 2010, in the last decade, I must say that we've had great improvement in science all around. The stents have grown thinner, the polymers have become stable, and in fact, in many ways, less thrombogenic and more in fact, protective. And then we have better optimization of stent implantation with imaging techniques. So at the moment, we're truly not very worried in clinical practice whether a stent has no polymer or has biodegradable polymer or has a fluorostable polymer. So I want your comments on that we're far ahead of what we were 10 years ago. And that's why Adnan, I'll just say this, the 1.2% thrombosis rates at 1 year, or 1%, are actually the ones which were achieved by Absorb, in the Absorb 4, and actually at that stage, it was felt that the 1.2% is huge because we get stent thrombosis rates of 0.5 and 0.4 and 0.2% in the present randomized studies. So we moved so much ahead in 10 years.
No, Ashok, you are right. We have very good options for drug-eluting stents, but not too many. I think that the first thing to look at the drug-eluting stents is how good are the data, how good is the evidence supporting these stents? Because, you know, there are different stents, but not all have a supporting evidence from randomized trial. And that's why this is the first thing to distinguish between the drug-eluting stents. On the other side, it's right. We have several good options in this. So there have been also concerns about the polymers, but at the end, we don't see any big difference for that. So that the question is, what are the additional benefits with novel drug-eluting stent technologies? And we have discussed in the before about the bleeding risk, about the length of dual antiplatelet therapy. And this is, for me, the topic which will attract most of the interest from our side. That means that which is the stent that allows the shortest duration of antiplatelet therapy, because we are concerned now not so much with stent thrombosis, but we are concerned with bleeding risk. And I think that this VIVO, the ISAR, for example, might be a very good option in this case. And we have very old patients which are at very high risk of bleeding. So that's having such stents in the hand, you can also be more flexible in the definition of the length of dual antiplatelet therapy. So that's just to say that we have made a lot of advances in the drug-eluting stent technology. We have very good stents for with respect to the safety and also to efficacy.
Sure.
But
so
you see that also after 1 year, there are problems with them. You see an increasing rate of target lesion revascularization. You see an increasing rate of target vessel revascularization. So I don't think that we are done with the optimization of drug-eluting stents.
So I'd pass this on to Dr. Ashwin Mehta. Like I said, the guru, the senior most member around the panel today and on the screen. Earlier we used to say on the podium. Now we have to say the senior most member on the screen today.
Thank you. Thank you, Ashok. It's so delightful to be interacting with you.
Thank you.
My point is this, that long ago when there was first Endeavor stent, where the polymer was phosphorylcholine, and trials there, the stent thrombosis rate in Endeavor group was very, very small. So true that the polymer does have impact on the stent thrombosis, but also I have a question for Adnan Kasrati, that we've been concentrating about the polymer all right, but the two arms, the drugs were also different, zotarelimers versus sirolimus. So whether that has any impact on final outcome or not, that I think a question. And yes, agreed that that dual antiplatelet therapy is a matter of concern for a variety of reasons, unanticipated circumstances arising like the accidents, unanticipated surgery and whatnot. So I do agree that we are in need for a drug, a kind of a stent, which will allow us to discontinue dual antiplatelet therapy. So this is about the question about the different drugs too.
So Matthew, we've been in all this discussion around, of course, I think prominent in our mind is balancing the bleeding risk versus the thrombotic risk. And by the way, I don't think the ISAR VIVO was an all-comer study, but more and more the studies are all-comers. And therefore, this true balance between bleeding and becomes very important, especially our patients are getting older, more complex, and we're doing multi-vessel, multi-lesion revascularizations and really complex lesions. So, Dr. Matthew, in your practice, at this time, firstly, does the choice of stent, is that important to you? And are you very confident of cutting down dual antiplatelet therapy earlier than what is the arbitrary recommendation of 1 year? And I'm saying earlier than that in your high bleeding risk patients with the current generation of stents, whichever stent you use. Matthew? Is Matthew around? Maybe I don't see him, which therefore takes me to Dr. Hiramath.
Actually, I learned from my patients. So many of them used to stop aspirin because of various reasons, including gastritis. So the Twilight study didn't really come as a surprise to me because complex stenting, patient himself takes away the aspirin, and yet they were very good, very stable, and no stent thrombosis. So I had this feeling long before the Twilight came into sort of light that the aspirin perhaps doesn't do anything great. And I think we are probably seeing more and more of it, that aspirin going away and sticking to either Tica or Clopidogrel alone. And now we have evidence with Prasugrel too. So my feeling is the stent quality has sort of upscaled itself to a level that the stronger antiplatelet requirement is clearly going down. So on that front, the ISAR VIVO is competing with a very high standard already set by the existent third generation stents. So it's going to be quite tough. So if it performs well on the ischemic side, I think it is going to be as good as any.
So I'm going to bring Singatuvelu in. And this is on the discussion now with yourself. We have a situation here at the moment where a number of new gen, and we call them the third gen stents, have demonstrated lowering of the DAPT in high bleeding risk patients, whether going on to single antiplatelet with newer P2Y12 inhibitors, or going on even with Clopidogrel, as was seen in STOP-DAPT, where you just do optimized and PCI and can get on to a single antiplatelet even in high-risk patients after a month. I'm not saying that's the ideal, but it's actually been dropped down to 3 months, and we've seen 1 month data from a number of third-generation stents.
Onyx 1.
Yeah, I mean, I wouldn't want to name the stents, but that was STOP-DAPT. There was the Onyx 1 data. So I'm saying the third-generation stents are competing very well. And then we have the optimization. We have the thin struts. We've got, despite complex PCIs. So now it's great that you did that study 10 years ago. Is this stent in the present scenario out of place because it was great for that time and is not so great for this time, present times? Or say non-inferior in the present time, but great for what was the science 10 years ago?
Sure.
I'm being provocative because your title was provocative and it said is the final des frontier. I think
Ashok, it will be the final frontier. It might be the final of the if we stop to improve the drug-eluting stents.
Sure.
So if we say now we are happy with what we have and we don't need better.
Right.
So this might be the title will be valid not only for the VIVO ISAR but also for a few other drug-eluting stents that have a supported evidence from randomized clinical trials.
So Singatuvelu, what is your present strategy around? I mean, I think it's a great stent. I think there's a great science behind it. I was actually just trying to position it into my practice. And I think that 10 years data is sound. It's profound data, looking at that flat curve, extremely low curves. So it's a great science in itself. Singatuvelu, in your practice, are you clearly worried about the bleeding risk in the patient? Are you moving away from the one year DAPT, which is arbitrary? And what is your practice at the moment getting down in your routine? I'm not talking about highly, I know that it has to be a balance between thrombotic and the bleeding risk, ischemic and the bleeding risk. But in your practice, are you changing your practices specifically to the patient, tailoring it to the patient?
Yes, of course, patients with the high bleeding risk, with the high precise DAPT score, or elderly patients with multiple stents, definitely that concern is there. And particularly as we have patients who are for major surgery, we have to do a stent, then we really want to put a stent which has been proven for a short DAPT. For patients who are having a severe disease who's going for a major surgery, if we want to do a stent and then send them for surgery, where you want a very short DAPT. So such situations want to specific stents which have shown benefit with a very short DAPT, for example, 1 month DAPT.
So Dr. Hazra, so
yes.
now I'm going to ask you this very specific, based on what he said. We have a patient, and he actually is he's a high bleeding risk patient. Just accept the fact. He's just had a recent bleed, but you've actually needed to put 2 stents into him. Would you take up this non-polymer coated stent? I mean, this is a great dual drug delivery. It delivers drug at a time. would you actually implant this, or would you implant any of the third generation stents? Would you have a preference for stents, knowing that you're going to actually have a very short DAPT, unpredictably short DAPT? The guy could bleed again in 2 weeks time. He may bleed in 6 weeks time, but he's had a previous bleed, or he may actually need a surgery in 6 weeks time. What is your thought process when you select stents in these patients?
Thank you, sir. We have biofreedom data for high bleeding risk people like elderly, on oral anticoagulant, those who have frail, those who have cancer. So you already know that polymer-free is a better stent, but we are moving from good to better. Better to best, we still do not know. Like Cobra ZDS is only 15 days of DAPT. It's not been marketed. And when Dr. Mehta was asking whether it is thinner stent or less drug or a different drug, that's a question. Suppose you compare with Giants, then your VIVO, then your Cobra ZDS, it may go down to 15. So you're absolutely right. We are moving towards a single drug. Maybe Ticagrelor is good enough, as Roxanne said in ESC, that perhaps with Ticagrelor, I don't need aspirin because the platelet inhibition is almost 90%.
Yes.
So you're quite correct that if somebody having high HBR risk, you can use the third generation and fourth generation stent like VIVO ISAR. This is my practice for last 1 year. I use a lot of VIVO ISAR in this group. You're right, sir.
So
one question. Sorry,
I was just going to just address this to Adnan. This is the sort of situation. Yes, I'd love to use this device. After all, it's not got a polymer. Do you have a data for extremely short DAPT with this stent in the present times? Do you have data for, say, 3 months? Do you have a data for 1 month DAPT? In, any data of the stent for 1 month DAPT?
Ashok, if we change the practice in our center, we change it on the basis of randomized trials.
Correct.
And unfortunately, we don't have done this kind of study. And I expect this study to be done in India.
Great. No, thank you.
I mean, so just to, we have also done a favor to science and to Resolute with our studies.
Right, you have.
Because these two studies, ISAR Test 4 and ISAR Test 5, they are the only 10-year studies also for science and for Resolute.
Yes, you're right.
Not only for our stents. So what you are saying now is based also on our data. If you are saying that the other stents are safe, because our data show it also.
Sure, sure. Ashwin Bhai, you're saying something.
Yeah, I was trying to tell you, Ashok, that when you come to a stage when you want to continue a single antiplatelet therapy after a certain period of time, you have choices. And whereas I know that the 45% of the sites are blocked by Clopidogrel, and much more, as Prakash Hazra said, by Ticagrelor. At that point of time, what would be your choice? Aspirin, Clopidogrel, or Ticagrelor? I mean, one single antiplatelet, you have a choice. So which one would? I'm asking you, Ashok.
So you're asking me, my choice would be Ticagrelor definitely as a single antiplatelet. You see, Stop DAPT, Koreans and Japanese, by the way, Japanese or Stop DAPT, it did the study, it did it with Clopidogrel. The Koreans did it with Clopidogrel, keeping Clopidogrel after 1 month. We have such unpredictability of Clopidogrel, and Onyx one was keeping one P2Y12 inhibitor, which was either Clopidogrel or Ticagrelor. I am concerned about those studies because we don't know the predictability of Clopidogrel and its resistance in our Indian settings, and unless we do the CYP2 PY19 allele regularly, we won't know that. So it's better to actually have Ticagrelor as a single antiplatelet than Clopidogrel as a single. Can we move over now to the next one? Adnan, were you saying something?
No. Yes, due to the question that was done, what kind of antiplatelet therapy to use as a single antiplatelet? We are planning, and we are at the end of all planifications, the ISAR-REACT-6 trial, which is a trial of more than 9,000 patients, and evaluating in a randomized double-blind way the need for aspirin after discharge in patients who are getting prasugrel or ticagrelor, not those with clopidogrel, because what you said also, the variability of the platelet response.
Correct. Thank you.
Ashok, is anybody doing this ticagrelor beyond 1 year? Like in Twilight, it was 90 twice a day, 90 milligram. Is anybody doing with 60 milligram?
Yeah, Pegasus was with 60 milligram twice a day.
No, but it had aspirin. I'm talking of
aspirin.
I'm talking of 60 milligram without aspirin. Is anybody doing it?
No. No.
I think that is another worth evaluating, because.
But in the ESC guidelines, it figures as its use beyond 1 year in preventing myocardials in high-risk patients at 60 milligrams twice a day. Based on
beyond 1 year is Iroraxol. There is no scope for ticagrelor. This Compass-trial, because of the Compass-trial, DPI has taken over ticagrelor because of their benefits.
Can we get on to the next one? Yes. Because this is going to be very relevant. The next one is going to be extremely relevant, because I think the new ESC guidelines on non-ST elevation MI, ACS, came after 5 years. And it had some very impactful data. And the impactful data also arose of the ISAR-5. And the important changes, we talk about ticagrelor is going down and prasugrel resurgence. We mentioned ISAR-5 in the beginning, but it's actually figures in the new changed guidelines for non-ST elevation MI ACS. And there are some very seminal points in that. And I think, again, it brings us to the same balancing the bleeding risk versus thrombotic risk. And before Adnan goes on to that, I just must say, we talk about these risks, but we talk about these as static in time. We only judge them at the time we do PCI. But we must remember that the two risks, the pendulum, can swing the very next day from a person who had low bleeding risk and high thrombotic risk. In a week's time, could be high bleeding risk and a lower thrombotic risk. And at month's time, that would change into a very high bleeding risk and a lower thrombotic risk. So it's a dynamic and a fluid situation which we need to assess patients at every month as we go by. At some stage, that thrombotic risk would go high and would go small, and the bleeding risk would go high. We actually, therefore, define it for our patients. And I think Adnan is the best person to talk about that. I would get my other colleagues in for the next discussion, which is going to happen after this. And therefore, Adnan, over to you on the new ESC guidelines, specifically focusing. I mean, the guidelines are huge, so you're not obviously going to dwell on every aspect of it. But certainly, there was great parts in it about balancing the bleeding risk and a focus on bleeding risks versus the thrombotic risks.
So, thank you. It's again. So the same problem as always with my. Are you seeing them?
Not yet.
Not yet. Okay. No, it's
on the bottom. So on the bottom, you can see the share screen option.
Okay, okay. And now?
Now, yes. You can see your side.
Okay. Ashok, you said the very right thing. So I am also of the opinion that it is very difficult to define the length of antithrombotic therapy just at the time of stenting. So you have to monitor the patient and to change the decision after seeing what is the reaction of the patient in sense of bleeding and thrombosis. And even the Twilight trial, it led 3 months for doing that. So only the patients that didn't have events during this time were included in the trial. So it's this is the talk about the new ESC guidelines on STEMI. As Ashok said, it came after 5 years. It was the first time because as a general rule, it was after 4 years, every 4 years that we got new guidelines, and this time it took a little bit longer. So I would focus on 3 points here: diagnosis and prognosis, invasive strategy, and antithrombotic therapy. And I'll concentrate on recommendations that have been changed or are new as compared with the older guidelines. This is just to show that the diagnosis of non-ST segment elevation acute coronary syndromes is based on the clinical symptoms, on ECG and troponin, but troponin is getting more and more interest in the definition of not only diagnosis but also of the treatment. High sensitivity versus conventional troponin assay. So we have been used up to 10 years ago maybe to use the conventional assay, and you see here that the limit for the detection was very high with the conventional assay, and it is much lower with high sensitivity assays. We have done a very interesting study. It was published in American Heart Journal, unfortunately, because of problems with other major journals. But it's very interesting in the sense that we took patients who had a normal conventional assay, and we measured the high sensitivity troponin in these patients. And even for this category of patients, having stable or unstable angina, but not non-ST segment elevation myocardial infarction, you see that there was a categorization according to TER size regarding the prognosis of these patients at 4 years. That means that patients belonging to the highest TER type of high sensitivity troponin, they had a much higher mortality at 4 years as the other patients. That means that even for this category of patients who were considered normal on the basis of troponin before 10 years, a high sensitivity troponin had a very, very prognostic value regarding mortality at 4 years. So the most important thing, the most important new recommendation regarding troponin is this one here. The algorithm 0-1 hour was given recommendation class 1 in these guidelines. But you have to distinguish here that it is given this recommendation for validated algorithm, for validated assays in this sense. And you see a list of assays that fulfill this criteria. And here is the scheme used to rule out or to accept the diagnosis of non-ST segment elevation acute coronary syndromes if they have no increase at 1 year, at 1 hour for this algorithm here. The diagnosis is ruled out. If there is an increase after 1 hour in the high sensitivity troponin, they have to be observed or ruled in as acute coronary syndromes. Now, another change in the recommendation was to give also a class 1 recommendation. You see that the colors define the strength of the recommendation, with green being for class 1, with yellow for class 2A, and orange for 2B, and red for 3. Here we have a class 1 recommendation also for the 0-2 hour algorithm in the cases you don't have the 0-1 hour algorithm. And this is said also for these assays here that have validated 0-2 hour algorithm for high sensitivity troponin. The new thing also from this guideline is that they gave a class 3 recommendation to the measurement of CK, CKMB, and other markers for diagnostic purposes. But just don't forget, it's not for prognosis, it's just for diagnostic purposes that this class 3 is issued for these markers. So other changes between 2015 and 2020 are this one here. you remember that the algorithm 0 and 3 hours was given class 1 recommendation 2015, and now it gets only a 2A recommendation if you don't have validated algorithm for 0-1, 0-2 hours. On the other side, there is a change also in the strength of the recommendation for the CT angio for patients presenting with acute coronary syndromes. 2015, it was given a 2A recommendation. Now it is given a class 1 recommendation as an alternative to invasive angiography to exclude ACS when there is a low to intermediate likelihood of coronary artery disease and when cardiac troponin and ECG are normal or inconclusive. What's about the new recommendations and changes in recommendation regarding invasive strategy? Here you know the old categories of risk: very high risk, intermediate risk, and low risk, based on the older recommendation. And what has changed now is intermediate risk, it doesn't exist anymore. So we have all the three high risk categories: very high, high risk, and low risk. And also you see a new point introduced in the high-risk category: resuscitated cardiac arrest without ST segment elevation or cardiogenic shock. So here is the flow chart or the decision tree, what to do with patients coming with diagnosis of non-ST segment elevation acute coronary syndromes. If they present in the PCI center and have a very high risk for this, they undergo immediate invasive strategy within 2 hours. If they have a high risk, not a very high risk, they can undergo early invasive strategy within the first 24 hours. And the same also is applied if the patient is admitted or is presented in non-PCI centers. If it is a very high risk, they have to be immediately transferred to the PCI center. If they have a high risk, they have to be transferred within the same day to PCI centers. Otherwise, if they have a low, they have to be treated with a selective invasive and probably also to follow the guidelines for chronic coronary syndromes. Why it was introduced, this resuscitated cardiac arrest in the high-risk category there? This was due to the cohort study, which didn't show a benefit of immediate coronary angiography as compared to the delayed angiography in this. So that's delayed as opposed to immediate angiography should be considered in these patients with a 2A recommendation. But I have to say that more exact answer we'd expect from the Tomahawk trial, which was practically a German trial, and it was a recruitment. It is concluded, it's completed, and we are waiting for the results of these trials. It has almost the same design as the cohort study, and we'll know much better how these patients will be treated in the future. A new section or chapter was added about coronary dissection, which was not present in the older guidelines. There are 3 types of coronary dissection. This one here with multiple lumen, and this with long, diffuse, but smooth narrowing, and with focal or tubular stenosis as based in this study here. And we have recommendations, specific recommendation also for these patients. It's a rare situations, but now it attracted the interest of the task force to give also the issue recommendation in this situation. Only for type 1, for the first on the left side, it is recommended PCI or CABG in these patients. In the other cases, the best treatment is recommended as optimal medical treatment, and you see here only in patients with high-risk anatomy, with left main, proximal LAD, proximal C6, proximal RCA, and multivessel disease, you may send them for invasive strategy. What's about antithrombotic therapy? And we have discussed a lot up to now about this. which had different changes as compared with the 2015 guidelines. Just to start, I'm a little bit biased in this point here. That's why I'm starting with this. The choice of P2I12 inhibitor, prasugrel should be considered in preference to ticagrelor for non-ST segment acute coronary syndromes who proceed to PCI. And as I noticed in this during this webinar, so this recommendation is very important, especially for Indian colleagues, because they are still going to use ticagrelor in these patients. And what is the basis for this? What is the reason for this change in the recommendation? It is the ISAR-REACT-5 trial, which showed a reduction of death, myocardial infarction, or stroke with prasugrel as compared to ticagrelor in patients with acute coronary syndromes planned to undergo an invasive strategy. At the same time, prasugrel was not associated with an increase in bleeding in these patients. But I have to notice two things in this regard. First, we have used an adapted dose of prasugrel in older and also in patients with weight below 60 kilograms. And this is a very important factor which helped to reduce bleeding with prasugrel, because exactly these patients had the highest risk of bleeding, as shown in the publication of Annals of Internal Medicine. On the other side, a lot of patients with prasugrel in the prasugrel group did receive it very, very late after the diagnostic angiography, so that's entered the diagnostic angiography and PCI without platelet inhibition on board. That's helped to have a lower rate of bleeding in this case. What about other recommendation? It is not recommended to use pretreatment in patients in whom coronary anatomy is not known and an early invasive management is planned. You see here for the first time, it is given a class 3A recommendation to the use of pretreatment with P2I12 inhibitors. But on the other side, it is a little bit flexibility for those patients who are not planned to undergo an early invasive strategy. And here there is a class 2B recommendation for pretreatment in these patients. So this is the complex scheme of what to do with antithrombotic therapy in patients with non-ST segment elevation acute coronary syndromes. And this is the case of patients in sinus rhythm. You see that the bleeding risk also determines what to do with these patients. If the bleeding risk is low, you have to give 12 months of dual antiplatelet therapy. This is class 1 recommendation. And the combination are aspirin plus prasugrel, aspirin plus ticagrelor, aspirin plus clopidogrel in those who cannot receive them. And there is also the option with 2B to prolong the therapy after 12 months with either rivaroxaban or the other P2I12 inhibitor. But after the Twilight study, you have another option to stop dual antiplatelet therapy after 3 months and to go on with ticagrelor after the time. If the bleeding risk is high, the dual antiplatelet therapy is only for 3 months, and in this case is only clopidogrel recommended with a 2A recommendation. If the bleeding risk is very high, then you can also stop the dual antiplatelet therapy after 1 month and continue with clopidogrel after the time. So there have been a lot of prognostic scores for bleeding risk in the past, but the most used now are, it is the PRECISE-DAPT score and the RCHBR score. For the PRECISE-DAPT, it is based on studies on pooled studies with antithrombotic therapy, but I have to say that it has not got a very strong recommendation, the use of scoring system, because a lot of these studies have had excluded patients with a high bleeding risk. So that's our scores that are based after exclusion of high bleeding risk patients. Now, on the other side, we need also to define the thrombotic risk, because this is also important in defining the length of therapy. And here are a lot of criteria defining a high risk of stent thrombosis in these patients. And you see diabetes here, multivessel disease, also chronic kidney disease, etc. As technical aspects, you see the use of 3 stents, the use of treatment of 3 lesions, total stented length more than 60 millimeters, etc. And this define a very high thrombotic risk with class 2A. And there are also other criteria defining the moderate thrombotic risk and getting a class 2B recommendation. So we have also talked about the de-escalation of P2Y12 inhibitor therapy. And de-escalation on the basis mostly on the tropical trial, it gets a 2B recommendations just after to de-escalate with clopidogrel in patients taking a stronger antiplatelet therapy. Now, what's about that? This is a very important area for which there have been very important changes in the recommendation. Antithrombotic therapy in patients with PCI and indications for oral anticoagulation. And you see now the default strategy recommended for these patients is triple therapy for only 1 week. That means aspirin, P2Y12 receptor inhibitor, and anticoagulation with new anticoagulants probably for 1 week. And then it goes on with only NOAC or anticoagulation plus single antiplatelet therapy up to 12 months, and after 12 months, no antiplatelet therapy at all. If the patient is coming with a high bleeding risk, so there are differences in the recommendation for high bleeding risk and for high ischemic risk. Just these high bleeding risk patients, they get 1 week of therapy, and they have a 2A recommendation for longer, up to 6 months of OAC and single antiplatelet therapy. And after that, after 6 months, not after 12 months, only anticoagulation. For those patients who are at higher ischemic risk, the triple therapy is allowed, so to say, for 1 month. And after that, they get a double therapy with OAC and single antiplatelet therapy. But it's important to say that this change has caused a lot of discussion, because 1 week is the shortest period of triple therapy given at any time. So thank you very much. This was what I meant, the most important changes in the recommendation from the new guidelines on non-SS segment elevation acute coronary syndrome.
Thank you very much, Adnan. In fact, there's a tremendous opportunity here to discuss some of these recommendations. But I also wanted to tell you that sometimes I'm just fascinated by your science and your contributions to science. In fact, let me just say that I'm so fascinated by your contributions to the country. Do I see? Just a moment. Yeah, there I am. So to our country, because at the end of the day, your dual drug delivery is now an Indian stent, in a way, and is an Indian stent, and that's the contribution. You know, we now are proud to have an Indian stent which actually shows over 10 years that it stands perhaps lower in terms of any event rates, including stent thrombosis, than any of the established competitors. And that is a huge thing to say. And that's a 10-year data. And there are very few stents which have systematic 10 years data, and you created those 10 years data for us to have an Indian stent with a 10 years data which can benefit our Indian population as an indigenous device. So I think I have, every of your device, I've followed your devices and used them right from the time of the sirolimus directly coated Yukon stents when we got them in boxes and created those stents in our lab. And it's just science which you have made progress to the present time. So I'm very proud of that. So let me just move to really the context. And has Praveen left? Because I wanted him involved and I wanted Anil Dhalt to be involved. Anil, are you there? Because we see a smart picture of you, but if you there, do come out from behind the picture. But Ashwin Bhai, and I know.
Anil is there.
Yes, Anil is there. Anil, you have a recommendation now on the ISAR React 5 data about Prasugrel instead of Ticagrelor. Now that's a very powerful recommendation for non-ST elevation ACS. So what are your comments on that? I mean, I do value the drug, and of course Adnan has conflict of interest, and he expressed that by saying that we don't even use Ticagrelor, but we use Ticagrelor and we use Prasugrel. But I actually do value Prasugrel because it provides me greater reassurance, greater freedom from stent thrombosis, and just because it had those two issues, and let me just say the two issues were the few contraindications. You can't give it in the elderly, you couldn't give it in the people with low body weights, and the fact that you can't give it in the ER has made us use more Ticagrelor. But on the other hand, now the recommendations on non-ST elevation ACS is do not even pre-treat them. Do everything in the cath lab. Your comments now. Now the drugs are equal. You can use 5 milligrams, which he's shown. In those you felt you couldn't. So what do you feel now?
Actually, I had a little privilege of doing some benchtop work with Prasugrel, and for a very long time, I had not only been recommending that we use the Japanese dosages in Indians, but I've also been practicing it. So I'm only delighted that you know this is actually important.
I hope the benchtop work.
You knew it, so you provoked me into.
I'll provoke you further. I hope the benchtop testing with Prasugrel was not breaking the tablets into two.
No. We did not do that, and we really think that you can go down further. In fact, because the Japanese may be lower body weight than Indians as well, so they have a 3.5 milligram tablet in Japan. So we can actually quite comfortably, especially in the elderly, use 5 milligram low body weight. You can use 5 milligram, and definitely. I think as far as pre-treatment is concerned, both the drugs are to be avoided. Although, you know, because there's a Ticagrelor that started with an all-comers indication, which if you really look at why does the pre-treatment actually fail is because of probably higher access bleeds. And that is going to apply whether you use Prasugrel or you use Ticagrelor. Clopidogrel probably does not have time to act. So therefore, it's okay. But I'm sure if you did a study like that with Ticagrelor, it'll be just the same. So I think what has happened is a good recommendation. It kind of, because you're always joyous when, you know, you have this "I told you so" smirky look on your face. But yes, I quite like the fact that we've gone back to something which is definitely a robust treatment.
Thank you, Anil. That was very balanced. Singaravelu, your comments about this loading now only in the cath lab, balancing the bleeding risks.
No, I think I think once we have that option, I think we now have the option of using Prasugrel as well. And I think overall the pattern, we have more confidence in Ticagrelor. We've been using it for all these years, but I think with this data, I think we'll be moving to both the drugs and more Prasugrel because of the cost. The other thing, what was very interesting to me is the 1 week DAPT in patients with atrial fibrillation or oral anticoagulation. So that it can even be, I mean, very intriguing for a week of DAPT, maybe even applicable to the other patients as well, where you want to use a short anticoagulation and then follow with a shorter drug. Probably this needs to be studied.
I would like Veeb and both Dr. Veeb and Dr. Castrati to comment on what he said, that we, you know, the COMPASS data, well, was it the no, it wasn't the Compass, it was Augustus, which had told us certainly that we needed to give aspirin even in these patients with atrial fibrillation. If we use apixaban, we needed to give aspirin. We saw the advantage of aspirin in preventing stent thrombosis up to a month, and that's therefore ingrained in our mind that there was an advantage, and that was, Augustus was a great study, well done. It showed the benefits actually up to a month of using aspirin in addition to clopidogrel and apixaban in patients who had persistent AF and underwent PCI. For once, we are having a step back to say that 1 week, and it makes me uncomfortable because Augustus was a sound data. So I'd like this comment from yourselves.
Ashok, it was practically, I was coordinating the review process of these guidelines, and it was the point which caused a lot of discussion this 1 month. It was very aggressive, but it was, you know, that the guidelines of non-SS segment acute coronary syndromes came out together with the guidelines for atrial fibrillation.
Yeah.
And so they both met together or discussed together, and the pressure to shorten it came more from the experts of atrial fibrillation than our colleagues of interventional cardiology. Because, you know, this kind of concerns has been also after the trials on NOAC, because there are also meta-analyses showing a little bit higher stent thrombosis rate.
That's right.
Yeah, yeah. And that was the concern. But on the other side, 1 week was a little bit too short because Augustus was using for a median of 10 days or 2 weeks also both therapies. And that was the problem. But on the other side, you are better off if you have a decision for all.
Right.
So it might be that the stent thrombosis, but so the numbers were very low to take decision on that side, and so it was like this.
Right. Okay.
It was like this. It's not everyone was happy with that, but it's always like this with recommendations.
Right. Azra, yourself?
Yeah. Thank you, Dr. Kostri. You know that you have said that 30% of the populations are clopidogrel resistant. That means 90% of the Augustus and 30% of them practically not on any antiplatelet. So perhaps the NOAC is also an antiplatelet. So the game of atrial fibrillation, PCI, NOAC we still do not know. But maybe it's a myth kind of lab for aspirin, lab for membrane in your stent, and lab for aspirin in your PCI is a kind of elusive thing. We have to wipe it out from our memories.
Yeah, you are right on that, and that's why also when we planned the ISAR-EX6 trial, we thought we should include only prasugrel or ticagrelor patients and not clopidogrel patients. On the other side, if you look back at the evidence, it is true that a high reactivity, platelet reactivity to clopidogrel is associated with the worst prognosis. But on the other side, we haven't been able to change this. So even with increasing the dose of clopidogrel or changing to prasugrel, there are trials on that. So we have little to do with changing the prognosis of patients with a higher platelet reactivity to clopidogrel. And this is also an aspect. So it is true that it is associated with high risk, but it's also true that we are unable to change the prognosis of these patients.
So Ashwin Bhai, yourself, you know, you saw the recommendations, and I always get very confused about this rivaroxaban, which comes in at 2.5 twice a day. Is that a part of your practice? Because it keeps coming up again and again, and I still don't know where to fit this rivaroxaban 2.5 twice a day in my practice. Wow. of dealing with patients. And I'm not talking about, obviously, that's not the dose for AF. That's the dose for cardiac events. So where does that fit in into, or do you use it? Do you ever?
Muted.
Unmute, sir.
Unmute.
Unmute, please.
Unmute, sir.
You'll have to unmute yourself. Ashwin Bhai, you'll have to unmute yourself.
Yeah. Ashok, I'm never first to change and last to accept. So I sit on the fence and see. I know they've been recommending it for congestive heart failure patients also, or left ventricular dysfunction. But Ashok, listening to everything, if the patient has atrial fibrillation, high thrombotic risk and high bleeding risk, would you not consider surgery? And secondly, I'll pray to God that God tomorrow morning give me a case with low thrombosis risk and low bleeding risk, so that I can do comfortably my angioplasty. Anyway, that's the lighter side of it. But I think basically what I've been practicing for SPAF, the stroke prevention in atrial fibrillation, I generally use either dabigatran or apixaban, and we've been practicing 1 week of dual antiplatelet therapy, and then go back to single antiplatelet therapy with any one of NOAC which we have been using in general practice.
Right.
About, can I?
Yes, go ahead. Yeah, please.
About the rivaroxaban, I use it routinely for patients with high thrombotic risk, and particularly have a young patient, which we very often see, a diabetic patient or a chronic kidney disease, patients who are very young. We have multiple stents implanted. Now it's there in the guidelines to go beyond 12 months to continue with low dose rivaroxaban in these patients.
With single antiplatelet.
Single antiplatelet. With aspirin.
Correct.
Yeah. Right.
Yeah. So it does.
What about heart failure? Sorry, say it, Velu.
Heart failure as well. Yes, heart failure as well.
Yeah. Okay.
Also, we are using very, very rarely, and mostly in patients with aneurysmatic coronary artery disease. You have seen sometimes very large coronary arteries that have a high risk of thrombosis, and we are using it in that. But it's rare.
No, that's I think a good indication, where sometimes we just continue to give them DAPT, but it's better to give them a single antiplatelet and rivaroxaban. These are patients who present at ACS regularly because they have ectasias or aneurysmal arteries.
Yeah. Especially, sir, one more point, in COVID situations, I am practicing this. This is again intuitive and provocative. The 2.5 milligram, those patients who had multiple stent from Ashok Shahir, Dr. Mehta, they come back for follow-up in Calcutta. I have started, I don't know, this is provocative. I don't want to take those risks. The high-fi patient, very influential people in the city, so I do not want to take any chance.
Can I just make a small point, sir?
Please do.
You know, to me, the trial of the last 2 years was defined PCI. And if you believe that 24% of all PCIs had suboptimal physiological results, as was demonstrated, then maybe there is more to our performing the PCI and maybe a little less about the drug that we are using or the dose that we are using. We have a lot of choices today. And I think we need to not have one-size-fits-all solutions, but have tailor-made solutions to dovetail each individual's problems.
So I think, this is a great comment. And I want to therefore emphasize this very aspect, that while we rely on antiplatelets, I mean, the Japanese in STOP-DAPT showed this. You actually they do IVUS in every case. And even with a drug like clopidogrel monotherapy, of which we call unpredictable, those guys had stent thrombosis of 0.3%. It was almost like they were giving them nothing after a month. At least 25% of the patients may have had nothing after a month, but they were IVUS guided, totally optimized PCIs, and they were not simple PCIs. So I think what we're saying is that there's a lot more. So say example, Adnan, and a final question to you is that you've got this patient who actually is in front of you, says, I cannot take aspirin at all. You give me aspirin, I go out into a rash. And while you can say, I can always desensitize these patients, but you haven't got time to desensitize him. He will not take aspirin. And you therefore are here, now, there. And you know that whatever you give him, you only have a single antiplatelet to give him, or you can add on, some other vague antiplatelet regimens. But you may actually also, he has a bleeding risk also, and you know that whatever you give him is just going to be for a month, and may not be there for a month. This guy's also had a bleed not too long ago. He's known to have esophageal varices, and he's aspirin intolerant, and he's on your table. That's where I do believe that the strategy of optimization will allow you to get him on a single antiplatelet ASAP, maybe a single antiplatelet right from the start, maybe single antiplatelet can be discontinued whenever you want. Now, I want your comments on that.
So you are, I am not so concerned. I'm not so concerned with removing aspirin, Ashok.
Yeah.
I would say for those patients who cannot tolerate aspirin for any reason, I will go to Prasugrel or Ticagrelor,
right.
Prasugrel for me, and because of what you said, because of the high proportion of patients with non-response to clopidogrel, and also I would not hesitate to stop after 6 weeks, 1 month, 6 weeks altogether, if the risk is very high for bleeding. I think that we have done the good experience now with the quality of the work we are doing in the cath lab, with the quality of the stents we have now. I think we are also safe after stopping, after a short time, altogether antiplatelet therapy, provided the patient has increased risk of bleeding or need. So, because I would say aspirin has never been shown strongly that it prevents stent thrombosis. So we have data for P2I12 inhibitors, but there are no specific data for aspirin.
Great, because I would like to just conclude and add on to your comments by saying image optimization, new P2Y12 inhibitors, and add in VIVO ISAR stent. And if you combine all these three, then you can actually stop the APT even after 6 weeks. You don't need to say that. I
have not said it.
I'm saying that so, you have this combination and you actually don't need aspirin, you don't need long-term antiplatelet therapy. You can stop antiplatelet therapy whenever you want.
As I see, you agree with the title of my talk.
Absolutely.
Okay.
Absolutely. I'm proud of it. In fact, I'm actually proud of the stent. It is a fascinating thought process, and I've always appreciated that. So, any final comments from any of my panelists?
Yeah, I think with regards to everybody, like your student, the ischemia trial has changed the whole game of coronary artery disease, PCI. Maybe we don't need stent in chronic stable angina, but you cannot get away from aspirin for the first month in acute coronary syndrome, STEMI and non-STEMI. That's my last comment. Over to you, sir. Thank you.
Okay, and Ashwin Bhai Sengetuvelu, and if Anil Dhal is still there, your last comments on this great session that we've actually had, some specific learning which you believe that we've got to pass on.
Ashok, it makes quite logical that when we know that the clopidogrel is capable of blocking 2B3 receptor sites up to 45% and ticagrelor to 90%, barely 15%. So it does make logic that when you have to switch over to a single antiplatelet therapy, you can choose ticagrelor if you are worried about clopidogrel resistance, or prasugrel. Prasugrel for Dr. Kastrati and ticagrelor for you and me.
No, I'm actually in favor of both drugs, but prasugrel's got some very sound data. So,
okay.
Sengetuvelu, yourself? Oh, good. And Anil?
So I just think that we've got lots to learn.
Yeah, that's right.
We still have lots to learn.
I think it's been a great session. I think it's been wonderful. Thank you. Thank you, our international faculty, Adnan, Dr. Vibe, yourself, for having brought ESC to us, and not just brought ESC to us, brought intricate thought processes about daily patient management. How do we make it safe and most efficacious for our patients? For providing science, for providing long-term safety with your tremendous research on the stent. 10-year data is very little, is available with very few people. And it's always reassuring to see that you have a durable and reliable stent in your hands in addition to whatever we discuss about antiplatelets and stent and optimization. I think it just makes us do better and better every day. And the more we talk to you, and I think you should both appear every month so that we can continue to discuss maybe case discussions next time, so that we can continue to provide the best for our patients in India. Thank you very much for being with us.
Thank you too.
And thank you, my panelists.
It was a pleasure. It was a pleasure.
Stay safe.